Good afternoon to everybody, and welcome to this session on the science-based response to COVID-19. Qatar has seen a very big epidemic of COVID-19 over the last months. We are now in a more stable situation, and I think that we have played very intensively, the role of science-based evidence-based policy in this country. I mean, there's been a lot of work around the production of data and information to inform policymaking. And some of the work which has been done through a scientific committee, which saw the participation of the most, leaders in the research, in public health research in the country. Some of these leaders, such as the most active leaders in this effort, are here with us in our roundtable. Let me introduce them to you, and I will ask the colleagues to raise their hand just to make them recognized. So first, I'd like to introduce Professor Michael Frenno. Professor Frenno is a clinical scientist with interest in heart failure and heart muscle disease. He has done an outstanding career in academia and healthcare institution, and in May 2018, he took the post of Chief of Scientific Academic Faculty Affairs in the Ahmad Medical Corporation. Professor Michael will speak about the research funding awarded and research outputs today. Then, we have Professor Late. Professor Late is a professor of infectious disease epidemiology at the Weill Cornell Medical Qatar. Medicine Qatar. He is also director of the WHO Collaborating Center for Disease Epidemiology Analytics on HIV/AIDS, sexually transmitted infection, and viral hepatitis. And previously held academic and research position in United States, in London, and in Japan. His research work has been very important in formulating the public health policy here in response to the COVID. And we'll talk about a science-based approach to inform the national response and the epidemiology of COVID-19 in Qatar. Dr. Adil Boot, Professor Adil Boot is Professor of Medicine and Professor of Population Health and Population Health Sciences at the Weill Cornell Medical College, New York and Doha. Professor Boot has numerous senior academic positions in the United States and the Middle East, and he has published many papers, more than 180 papers in many journals, and participated in a lot of important conferences, and he mentored a number of young physicians and researchers. And he's done also a great work in these months to understand better the COVID epidemic in Qatar. Finally, I have Dr. Hadi Yassin. Dr. Hadi is an associate professor of infectious diseases and section head of research at the Qatar University Biomedical Research Center. He has worked at the Vaccine Research Center in the NIH for over 5 years, and then was a research fellow working on virology, microbiology, immunology, and he also has a very impressive record of publication. Hadi will speak about an holistic approach to tackling COVID-19, highlights from Qatar University sequencing and serological research. Qatar University, as well as Weill Cornell, played a very important role in this area, showing how we can link academic institutions with actually public health policy. So let's start with presentations. I would like to ask Professor Late to start with his presentation on a science-based approach to inform the national response to the epidemiology of COVID-19 in Qatar. Professor Late, you have the floor.
Yeah, thank you very much, Dr. Roberto, for the introduction. So the first case of SARS-CoV-2 community transmission in Qatar was discovered earlier in March of this year. However, before even the discovery of this very first case, this country has already adopted a science-based approach to inform the national response. And this happened through different strategies. One strategy was to forecast the healthcare and isolation needs to prepare for the epidemic, and also through assessment of the impact of different social and physical distancing restrictions to flatten the epidemic curve. This slide shows one of the very first forecasts that were done to estimate healthcare needs, which also factored the nature of the country here, where we have an urban population and a very large labor population, to make sure we address all of those needs together. And these forecasts proved to be largely actually quite accurate and not far from what eventually happened, which allowed the country to prepare well for the epidemic, and at no point the needs for healthcare in terms of acute bed hospitalizations or ICU hospitalization and other needs were actually above or even close to the health system threshold. So this is the case for forecasting of healthcare needs, but also we needed to forecast isolation and quarantine facilities because of also our special situation where we need these facilities and we cannot count only on home isolation and quarantine. So these also were forecasted through a scientific approach of mathematical modeling. And at no point we were actually having any issues in dealing with the demand for these facilities. So even though there was debate in many countries about which approach to adopt in countering the epidemic, here in Qatar, from the very early on, there was consensus that we are going to do the epidemic suppression approach and flattening the epidemic curve, which is exactly what actually happened. And we were successfully able to flatten the epidemic curve, as you can see here in this figure. So we had more than 75% reduction in acute care hospitalization, in the peak of acute care hospitalization, or in the peak of ICU care hospitalization. So in this regard, it was successful, and all of this work was also informed by mathematical modeling. So this was one aspect of the science-based approach. Another aspect is really just monitoring, tracking, and forecasting and analyzing the epidemic. This happened through different ways. Here is one example of it, which is predicting the evolution of the epidemic and when we are going to have the epidemic peak, which was predicted also correctly weeks in advance. So it allowed the country to plan ahead for what is going to happen. This tracking of the epidemic continues to, of course, till the present day. Currently, the focus on monitoring the reproduction number. This is more like a temperature scale of the epidemic, and it provides us an early warning system of whether a second wave is forming. And so far, things looks really good. We do not have yet any sign that there is an immediate second wave coming in Qatar. Another aspect, another application of the science-based approach has to do with the timing and manner of easing of restrictions. In fact, this is probably one of the most even influential proved to be. So the decision to ease restriction and how we are going to ease restriction was informed by modeling analyses to look at different scenarios and different time, different durations, and so on. And by going through all of these scenarios, it was becoming clear that timing is very, very important, and really it's very tricky as well. And eventually it was decided that the best scenario is to start easing of restrictions on June 15, which is exactly what happened. And the reason for this date, because through these simulations of using mathematical modeling, starting easing of restriction in this day or any time after will minimize the risk of a second wave coming in the immediate future, and also will avoid us the need for intermittent application of restrictions, which could hurt the economy and society. So this was the decision for easing of restriction. I mean, specifically the timing was informed by science-based analyses, which proved to be a very effective strategy. So far, now we are over 6 months since the epidemic peak in May. And so far, as you can see in this figure here, no second wave has materialized. And we have been able to ease most restrictions in the country, and the economy is back on track. And we have stability and functionality now for several months. So the examples I have just shown are examples in which science was integrated in the very fabric of the national response. But the country has also invested in the conduct of a series of major epidemiologic studies to understand the epidemiology of this infection, and also, of course, to support the national response. I'm going here just to give one example, which is the study of assessing the risk of SARS-CoV-2 reinfection. And this study was possible because we do have excellent databases in the country. We have centralized and standardized databases for all COVID-19 related data, which allowed us actually to conduct such work. So through this study, we were able to confirm that reinfections do in fact happen. And we have now a definite confirmation that at least 4 reinfections have happened. We have the confirmation through viral genome sequencing. However, the more important part of this study is that it allowed us to estimate the risk of reinfection, which is actually the first time anyone was able to actually estimate this risk, which turns out to be less than 2 in 10,000 infections. So out of every 10,000 infections, only 2 are more likely to be reinfected. And all of these reinfections were actually mild. None of them were severe, critical, or fatal. So even though reinfection does happen, and it is there, but it's really, the risk is so small to be of much public health significance. As a result, now this allows us to ease some of the restrictions and to move with changing with some of the guidelines, which is actually happening nationally, and not only here, but also internationally. So, for example, the US CDC has recently changed their guidelines for quarantine. And one of the reasons for this change is this actually study conducted for Qatar for the risk of reinfection. So in conclusion, the science-based approach to understand the epidemiology and to inform the national response minimize the toll of this infection and its disease burden in the country, prepare the country well to confront the epidemic, facilitated functionality and stability for the economy and society, and inform the global understanding of the epidemiology of this infection. I think we had really quite a success story here. And last but not least, I just want to acknowledge all the different teams working in all of this work that presented here, the funders of this work, as well as the excellent collaborative working relationship at the national level between the Ministry, Hamad Medical Corporation, and the academic sector. Thank you very much.
Thank you very much, Professor Late. This has been a very, very interesting presentation. And actually, I mean, I think this is one concrete example of the way in which science can inform policy. And this is not so common around the world. And so I think it's an important contribution that we are given to this approach, which needs to be more strengthened for responding to epidemic, but also in general to the burden of disease or different problems in the world. Now, I just wanted to remind the people who are watching this that they can ask questions, and then we will try to leave a few minutes at the end to answer the questions, should you have any of them. So the next speaker is Professor Adil Boot. Professor Boot has been very active also in making a number of analyses on the data and to understand a bit better some aspects of the epidemic here. So Adil will speak about hospitalization and hospital capacity in Qatar during the COVID-19 epidemic. Adil, the floor is yours, please.
Thank you. And just let me know if you can see the slides at this point in time.
Yes, we see them, but we see in the presenter's view, which is 2 slides at the same time.
Okay, let me just switch that then.
Okay, that's okay.
Is that better now?
Excellent, yes.
Okay, so first of all, I would like to thank Vish for allowing us this platform to share some of the knowledge we've gained in combating the epidemic of COVID-19. So what I'm going to talk about today is how we cope with the hospital capacity needs of the country and what were the changes that occurred during this pandemic compared to what was going on before that. So I will talk about change in hospitalization rates before and during the pandemic in Qatar. Changes that happened in major reasons for people coming to the hospital, changes in emergency department volumes, acuity of presentation to the emergency departments, overall, as well as the volumes and presentation patterns of cardiac symptoms and diagnoses. So this is the early epidemic curve for Qatar. And as Professor Leth pointed out, the first community transmission occurred in the first week of March, but the first diagnosed case, which was an imported case, was at the end of February. And soon thereafter, a lot of public health measures were put in place, which actually helped to curb the pandemic in Qatar, which the data that Professor Leth has shared with you. Now, because of the excellent planning by the Ministry of Public Health and other stakeholders in the country, we anticipated that there would be an increased demand for hospital beds, and plans were put into place to address that. And one of the plans was to increase the hospital capacity by about 100% or so. So there were 2,900 new hospital beds that were added early on in the pandemic, which included 700 intensive care beds. And I think that was one of the major reasons why we were able to treat every patient who required any sort of treatment, from outpatient treatment to acute inpatient to the most intensive care that they could have gotten. This included 5 facilities that were added, including 2 new hospitals that were open in Masaid and Ras Laffan. They were designated as COVID-19 treatment facilities. And within the existing facilities, there was also a plan to reclassify some of them as COVID-19 treatment facilities, and others would be non-COVID facilities, which we would try to keep non-COVID patients in there. So very early on, we started seeing a drop in overall patients coming to the hospital, and then we started studying that, and now we've published a lot of data in this regard. So we studied 4 hospitals in Qatar: Hamad General Hospital, which is the largest tertiary care referral hospital, 2 subspecialty hospitals, Heart Hospital and the Cancer Center, and the major pediatric and obstetrics hospital, the Women's Wellness and Research Center. So as you can see in the slide, that year on year, there were significant drops in number of people coming to the hospitals. In Hamad General Hospital, we saw about a 9% drop in acute hospitalization in March compared to March of last year, while in Heart Hospital and the Cancer Center, the drops were much larger, between 50 to 75% drops. In the Women's Hospital, there was about a 21% drop in acute care hospitalizations. We also saw a drop in procedures, both elective as well as non-elective procedures. So on your right-hand side, there's a list of surgical elective and non-elective procedures that we saw a drop in. So we saw, for example, at Hamad General Hospital, about 50% drop in elective surgeries, but even non-elective surgeries dropped by about 20% or so. However, the good thing was that there was no worsening of any clinical outcomes in our patients during that period. One would anticipate that if people are not coming to the hospital for urgent care or emergency procedures, then there may be an increased mortality in the patients who are actually presenting, because the residual of patients that are being admitted are much more sicker. But fortunately, we did not see any increase in hospital mortality during that time. This slide also shows some of the flow metrics as well as utilization metrics, and only 2 things that I want to point out here: that while total admissions declined at all hospitals, the mode of presentation and disposition were relatively unchanged. In other words, the number of people coming by ambulance versus coming by themselves, and disposition, in other words, people who are being discharged to home versus to another facility, or in hospital mortality, were not changed at any of the hospitals in an insignificant way. We then started looking at the actual diagnoses for which patients were presenting, and we chose a list of certain diagnoses which we thought are such diagnoses for which patients must come to the hospital early on, or their outcomes would be adversely affected. These included acute appendicitis, acute coronary syndrome, stroke, acute fractures, cancers. And we saw that though these diagnoses would require patients to come in as an emergent cases, we still saw a significant drop of between 22 to 50% or so. So there was a decline in all major acute or emergency diagnoses. Concomitantly, we saw an increase in respiratory tract infection diagnoses that were being admitted to the hospital. We also looked at patients presenting to the emergency departments, and we saw a similar trend that at all hospitals, both the general hospital as well as subspecialty hospitals, there was a significant drop in patients presenting for emergency visits. Average year-on-year decline ranged between about 10% to 35% or so. We then also looked at what the acuity of these cases was, because our thinking was that if patients are not coming to the emergency department, they may be having more emergency cases in the community, and the residual that is coming to the hospitals and emergency department would be much more sicker. So decline in emergency department volumes was seen at all acuity levels. In other words, the most severe cases were also, we saw a decline in those, as well as less severely or less acutely ill patients. However, much larger declines were noted in lower acuity presentation. In other words, people who were less sick were less likely to come to the hospital and emergency department during the COVID period as compared to the same period in last year. We then further deep dived into these data to look at patients at heart hospital emergency room, specifically with cardiac symptoms, who were presenting to the hospital. And we also saw a decrease in number of patients presenting overall to heart hospital, and percentage of people who actually had cardiac symptoms compatible with an acute cardiac event. A 25 to 50% drop in numbers were seen in patients who had cardiac symptoms which were likely to be due to a heart condition. And there's a breakdown that we provide for all these cardiac symptoms out here in this slide. Finally, this is not related directly to healthcare admissions, but we also looked at healthcare workers, the infection rates, as well as reasons and setting of infection in these people. So it turns out that overall healthcare worker infection rates are not higher than any other place in the world. We are quite similar to what has been reported in several European countries. What was interesting to note was that most of the infections in the hospital, in healthcare workers, were not nosocomial, were not picked up in the hospital from the patients. It seems that healthcare workers were picking up infection from their contacts outside the hospital, or in certain cases from other healthcare workers in social settings, but not from patient. The infections were not being transmitted from patients to healthcare workers. So in summary, healthcare utilization dropped significantly in Qatar after the beginning of the pandemic. However, the good news is that thus far it does not appear to have any appreciable worsening in clinical outcomes. And I think the major reason why this happened was that we built up a very large excess capacity in the country, both for acute care beds as well as intensive care beds, so that we could take care of every patient regardless of their situation otherwise. What is next in this step is that we have a critical need to determine the effect of a rebound in numbers as the pandemic eases up, which it has started to, and restrictions are being gradually lifted. And as I mentioned earlier, proactive increase in acute care and ICU capacity of nearly 100% was probably the biggest contributor towards mitigating the effects of pandemic in Qatar. I would also like to thank and acknowledge the excellent work of a very large number of people in Qatar, starting with Her Excellency, our Minister of Public Health, our system-wide incident command center, the business intelligence unit teams who really have done a wonderful job of curating these data, MOPH staff and other teams at our academic health center partners, but most of all healthcare staff on the front line who have sacrificed so much to take care of all our patients. I will stop here and give it back to you, Roberto.
Thank you, Professor Adil. A very interesting set of data, and also very intriguing. I mean, to understand a little bit what are the reasons for that, in addition to the concern of the people to go to the hospital. Now, I would like to give the floor now to Dr. Adi. Dr. Adi will speak about a holistic approach to tackling COVID-19, highlights from QU sequencing and serological research. Dr. Adi, the floor is yours, please. We cannot hear you. Maybe you are muted.
Can you hear me now?
Yes, yes.
Okay, thank you, Dr. Roberto, for inviting me today to give some a highlight of some of the work that we have been doing at Qatar University to help tackling the COVID-19 epidemic in Qatar. So we know that coronaviruses have been circulating in a human for a long time. The first isolates were isolated in 1965, but interestingly, after 2000, we had like emergence or at least detection of 5 coronaviruses, including 3 that are pathogenic. And most interestingly, in Qatar, we have 2 pathogenic viruses circulating, the MERS that's in camels around the Gulf region, as well as SARS-CoV-2. So in that regard, it's very important to look at these viruses, understand how they are evolving, and try to detect any mutant strain that can evade the immune system and maybe cause more pathogenic illness. So at Qatar University, the objectives of this work was to sequence and characterize SARS-CoV-2 from patients with different demographic and clinical characteristics. And we also try to evaluate different serological assays, manual and automated, and also participate in assessing the seroprevalence of anti-SARS-CoV-2 antibodies in certain populations, specifically in the urban population. And we also we have the Biosafety Level 3 facility to isolate the virus and test potential drugs against SARS-CoV-2 and other coronaviruses. I just want to highlight here that in 2019, we were able to get the first Biosafety Level 3 facility for research, which is the second after the one in Hamad that's used for TB. And this is a mobile facility that it can be transferred anywhere in the nation in case of outbreaks. And as I just mentioned, this facility helped us to isolate the viruses, some of the strains that are circulating in Qatar. So in terms of sequencing activities, we have 2 sequencing platforms at Qatar University. We have the Illumina MySeq platform and Oxford Nanopore Technology Grid Ion, and we thank Qatar Genome Project for helping us in this project. So far, we have sequenced more than 700 viruses isolated from patients with different demographics and the clinical outcomes. In summary, we can say that we had multiple introduction of the virus in March, and during the peak of the infections in Qatar between mid-May and mid-June, there was an increase of number of detected lineages. But overall, most of the detected strains belong to the B lineage, which is very similar to the ones that are circulating in Europe. Currently, we are working with the Qatar Genome Project and Sidra to establish a database where we can store all these sequences along with demographic and clinical data and make them available for clinicians and researchers around Qatar. But meanwhile, we have been using and utilizing the GIS-8 platform to deposit some of our sequences. And as you see in here, that most of the viruses circulating in Qatar belong to 3 clades. And we can detect several mutations in different open reading frames, including the spike protein. But these are non-unique mutations to Qatar. They have been detected elsewhere. I just want to highlight here that it's very important to continue these sequencing efforts because divergent strains could emerge in the population, and most importantly, could be imported through incoming travelers, as we have noticed in some of the strains during May. One of the studies that we have conducted also to study the within-host diversity of SARS-CoV-2 in patients with mild and severe symptoms and try to identify certain mutant strains that could be related to the severity of the disease. Although we did not see a major difference in the viral sequences between mild and severe cases, it was interesting to see that in the severe cases, there was a higher within-host diversity. So it seems that at least in the severe cases, the virus is mutating at a higher rate, and that could be a factor for the severe illness. In terms of serological screening, so we were participating in a study with PHCC. This study is led by Dr. Mohammed Said and Dr. Hamda Qutba from PHCC. And we know there were other studies that are done in the worker camps, but this was done in the urban population. We have finished already 2 phases from this study. The first phase included around 2,000 participants. It was done between July and August. Knowing that PHCC have more than 1.3 million registrants. In summary, the overall prevalence, according to the serology screening as well as a PCR, was about 14.6%. We just finished the second phase and we are in the analytical stage, and we can say that the overall prevalence in the urban population is about 20%. The other serological work that we have done was to evaluate manual and automated systems, and the answers that we needed to answer: does all the assay provide the same sensitivity and specificity? Does the period between the onset of symptoms and sample collection affect the sensitivity of the assays? What are the best antigens to include in this diagnostic assay, whether the S protein, a full S protein or subunit of the S protein, or other antigens like the nucleic acid, and whether the pre-existing community to other coronaviruses would affect the specificity of the detection of the assays. And for that, we evaluated 4 manual ELISA kits and 4 automated systems. And these kits or the system either incorporated spike protein or nucleic acid or a combination of both. In terms of the study group, we had included samples, pre-pandemic and post-pandemic samples. We selected samples that are positive for other respiratory viruses, including some samples that are positive for seasonal and pathogenic coronaviruses like SARS and MERS that we have them from previous studies. We analyzed samples collected at different time points and for sure PCR confirmed COVID-19 samples. So in summary, just like with the summary, like it was the same, or the outcome was the same, whether it's manual or automated systems. So we have noticed higher sensitivity but lower specificity for those that incorporate both S and an antigen. We observed cross-reactivity to other coronaviruses, especially in the assays or system that incorporate the antigen. So there's a lot of cross-reactivity to the nucleic acid antigen, and the majority of patients developed IgG day 14, which is detected by the majority of the assays. In addition to the binding assays, we also have confirmatory assays that are adopted at Qatar University. So we have the serological virus neutralization assay, which is ELISA-based. We also have 2 serotype systems. We have the lentiviral and VSV, and those can measure neutralizing antibodies. Interestingly, although we have not tested a lot of samples, but the neutralization capacity or the neutralization level did not even reach 100%, even in the samples that have high titer antibody according to the ELISA assays. And maybe that explains why these antibodies wean really fast in a matter of months. And as I mentioned, we also have biosafety level 3, so we can do microneutralization assay on real viruses. By this, I would like to thank all of our collaborators: Hamad Medical Corporation, Ministry of Public Health, Qatar Biobank, Hamad bin Khalifa University, Qatar Genome Project, Weill Cornell, QNRF, Sidra, and PHCC.
Thank you very much, Hadi. Thank you for this very informative presentation, and also for showing in the last slide the large collaboration among the different stakeholders. Now, I would like to give, would you please, okay. I would like to give the floor now to Professor Frenno. We have only 10 minutes left, so I would like to ask Professor Frenno to speak about the COVID-19 research funding awarded and research outputs. Katia, can you put the slides on, please? Professor Frenno, the floor is yours.
Roberto, thanks very much for inviting me to present these data on research funding related to COVID-19 and research outputs thus far. Katia, are we ready with the first slide?
Yes, just 1 minute.
Maybe you can start introducing.
Okay, so Qatar responded rapidly to the COVID-19 pandemic by instituting a series of research funding mechanisms. If we take the next slide, please, Katia. So the first of these was Hamad Medical Corporation. The Medical Research Center at Hamad instituted a fast-track COVID-19 research scheme, which provided assessments and decisions regarding funding and rapid decisions regarding IRB approval or exemption. And to date, this has received 294 applications, has awarded 168 of these, and the funding committed to date has been just under 5 million riyals. So we've categorized the funding awarded, the studies awarded, into 4 different domains. Those related to occurrence of COVID-19, of which there have been 51. Those looking at outcomes, of which there have been 104. Those looking at basic methods, there have been 5 of these. And those looking at pathophysiology, 7. And you can see also according to subdomains, and they're listed here with the totals on the right-hand side. Qatar University also established an emergency response grant award scheme and received 73 submissions, 24 of which were selected for subsequent assessment, and 9 of these were awarded. 4 were in the social behavioral research category, 2 basic molecular research, 1 basic molecular and clinical, and 2 were e-health, and they're shown below. Next slide, please. Okay. QNRF also established a first rapid response call award scheme and received 230 submissions, of which 21 were awarded. I've listed them here, not time to go through them, but these are actually available on the QNRF website for those who are interested. And finally, the academic health system established a national award call for COVID-19 research with the stipulation that this should be internationally leading research and should involve research from across at least 2 of the academic health system partners in Qatar. It received 21 applications, of which 2 were awarded. The first on neurodegeneration in COVID-19 patients investigated with magnetic resonance imaging and corneal confocal microscopy. And the second, the impact of oxidative stress, micronutrient status, and exposure to heavy metals and environmental pollutants on outcomes in COVID-19 patients admitted to ICU. And together these received 1.4 million riyals of funding. So this is the funding landscape. What of the publications? And as of the end of last week, there had been 177 publications in PubMed on COVID-19 from Qatar. And we've used exactly the same scheme. Occurrence of COVID-19, there was 70, outcomes 85, basic methods 7, and pathophysiology 15. And you can see on the left-hand side the subdomains and the totals on the right. And noteworthy, particular interest in mental health, impact on health services, complications, and transmission and control. There's also been a huge effort to establish infrastructure to support research on COVID-19. And the first of these is the COVID-19 Biorepository, which is hosted by Qatar Biobank with support from the academic health system. Qatar Biobank has provided 16 staff members who have collected, processed and stored specimens from COVID-19 patients at the clinical sites during the acute illness and serially thereafter during the 12-month recovery period. And there is matched clinical data available. HMC's academic health system has provided 4.6 million riyals for equipment and consumable costs to underpin this. There is a fast-track access system for samples, including IRB approval and associated anonymized clinical data, which is screened by a data access committee. Currently, more than 2,000 COVID-19 patient samples from more than 2,000 patients are stored. And the second major initiative, which will go live on the 1st of December, is a COVID-19 research data warehouse, which aims to establish a single trusted source of COVID-related data to underpin both research activity and policy decision-making. And in brief, this aims to meet the diverse need of stakeholders, including access to data, scalability, governance and data protection, ease of use, flexibility to expand, ease of maintenance and sustainability, and ability to combine data from multiple sources. And indeed, it combines data from HMC, PHCC, and from a ministry's SAVES database. And the target data model includes the WHO minimum data set together with other items of data which were deemed to be important by our stakeholders. So I'd like to acknowledge the contribution of all of the partners and of the ministry, but also for this presentation, particular thanks to Dr. Saifuddin Badran, who undertook the considerable work in coding the grants and publications into domains and subdomains. Thank you very much indeed.
Thank you very much, Michael. This has been extremely important also to summarize the big effort which has been done by Qatar to contribute also to the knowledge on COVID-19. We have 1 minute left, and I have one question that I think I would like to address to Professor Late. And somebody asking, what will be, on the basis of the data available, the projection for the future epidemic in Qatar? Do you have any?
Yeah, it will totally depends on how much waning of immunity there will be. If there is very limited waning of immunity, we may have a second wave. This would be a worst case scenario, but the second wave will be quite actually small and smaller, much smaller than the first wave. If there is large waning of immunity, then of course we could have a very big second wave.
Okay.
But no signs so far waning of immunity. Thank you.
Thank you very much, Professor Late. And I think the time is over. So I would like to thank everybody for the presentations, for the great contribution, the great work done over the time by all of you and your teams. And I would like to thank also the organizers and those who have participated to this session. Thank you very much and have a nice afternoon.